about your answer. What are your thoughts? Pulmonic valve lies anterior to the aortic valves. Remember, the right ventricle is the most anterior structure in the heart, which means anything coming off of the right ventricle can be the most anterior structure. So the pulmonic valve comes off of the right ventricle, so that means that pulmonic valve lies anterior to the aortic valve. Does that make sense? I was just looking at your anatomy again, just seeing that. But we did talk about that part. This next one is a 63-year-old man presents to the hospital with an acute myocardial infarction that is affecting the lateral wall of the left ventricle. Obstruction within which of the following coronary arteries is likely responsible? So, lateral wall. So which one does your lateral wall? Okay, I'm here in B. Is that what people would agree with? Yeah. So lateral wall is going to be your circumflex. Your left anterior descending does the majority of your left ventricle, but the lateral wall, the lateral portion of the left ventricle is perfused by the circumflex coronary artery. Okay, good. All right, so I'm sure you've seen a cardiac physical exam on a note. And we break it down to RRR, no MRs or Gs. What the heck does that mean? Some secret language, right? So really it comes down to regular rate and rhythm with no murmurs, rubs, or gallops. So what's a rub? What's a gallop? What's a murmur? What's a regular rate and rhythm? What are those things? What do those mean? Because if you're going to use that kind of language in documenting your note, you better know what you're documenting, right? That's how you're going to get sued if you say, oh, there's no murmurs, and there's a loud one, right? So we got to know what our cardiac exam and how we document it and what those things mean. When you do the cardiac exam, it's going to be kind of in this stepwise fashion because you want to make sure that you have that consistency. There's going to be some things that you're going to have to add depending on what you're evaluating for. But at a minimum, you should be listening to the heart sounds, right? At a minimum, you probably should get their pulse rate. At a minimum, you should get their blood pressure. Those are your vital signs. It's vital for you to get those things in order to be able to do a true assessment of the cardiovascular system of the heart. Now, we have become too reliant on the ancillary studies in order to tell us what's going on. But really, the ancillary studies should be there to just confirm what we suspect. I shouldn't need to get a blood test to tell me that this patient is having a heart attack. I should already assume or have in my differential that this person is having a heart attack. I just want to confirm it and to verify it, right? So we become very bad at our physical exams because we have those ancillary studies at our disposal. But hopefully you'll become more comfortable with the cardiac exam so that you can go back to what those ancillary studies are intended for, which is simply in conjunction with to confirm and to verify. So when you do the physical exam, some of the findings of the cardiac exam are going to be very subtle. So you have to make sure you have the proper environment. So you have to have a quiet area to listen to the heart murmurs or the heart sounds, looking for murmurs. You need to have good equipment. So you need a stethoscope that has both a bell and a diaphragm component to it, right? So you can hear the subtle differences. And we're going to talk about in this lecture today which heart sounds or which murmurs you're going to hear with the diaphragm and which ones you're going to hear with the bell. The equipment is kind of undergoing a lot of changes. I've got an example of one of the newer stethoscopes out here that is connected with AI. I am not endorsing this, but this stethoscope will listen to the heart sounds. It will then compare what it hears to a database of like 10,000 different valvular disorders and the murmurs that are associated with them. And it can actually tell you, hey, this person has a valvular disorder with very subtle findings that you may not even be able to appreciate. Okay? I'm not encouraging that you have to go out and get this because it's a little more expensive than a good stethoscope, but it does come with an annual fee if you want to use the AI features. The other nice thing about this one is it does have like a 3-lead EKG, so you can kind of see rhythms, see if they're in like an AFib or some kind of arrhythmia simply by using the stethoscope. So some interesting equipment that is out there to help you with your physical exam. When we talk about the physical exam for the cardiovascular system, the same tenets of inspection, palpation, and auscultation that you've learned in ortho and all your physical exam classes applies as well. Okay? You're going to do these things and to help you differentiate normal from abnormal. And we're going to go through each one of these and kind of talk about the different things that we can appreciate on our physical by looking at just the inspection, by looking at what palpation is, and by auscultating, of course. So let's start with inspection. Kind of the first step is just to simply look at the chest to see if it looks normal. A normal configuration of the chest is that it is wider than it is deep, at about a 2-to-1 ratio, okay? That's a normal chest configuration. If we deviate from that chest configuration, imagine the additional stressors or the functional impacts that are going to happen if, for whatever reason, the chest configuration is distorted a little bit. And you can kind of see in these examples some of the different things you may be able to appreciate on your physical exam. So the first example, well, this is what it should look like normally up here where you have that 2-to-1 ratio of width to depth. But in pectus excavatum, excavate, you have a depressed sternum, and imagine what that is going to do to your cardiovascular system. Because really, what is it going to do to your lungs, which is then going to lead to problems with the cardiovascular system, right? It's going to interfere with blood return. It's actually also going to interfere with blood leaving the heart as well, okay? Imagine now you have pectus carinatum, so instead of having a internal deviation of the sternum, now it's actually popping out and looks more like a bird's chest. That's where the carinatum comes from, or pigeon chest. Now you have all this extra space. What does the body do with extra space? It fills it. So you may find things, organs moving around to fill that space. We see that with like diaphragmatic hernias where the intestines move up into the chest cavity to kind of occupy space that it shouldn't. Look at the COPD or the barrel chest. Now that AP diameter, instead of it being a 2-to-1 ratio width to depth, now that's distorted to now where you have more of a depth than you actually do to a width. And now that's going to change and distort kind of the configuration of the organs and their function. And then, of course, the last example is with scoliosis, how that curvature of your spine is going to affect the organs that are in there, also affect the expansion of the ribs to create that negative pressure environment that you need to help with venous return. So imagine how deviating from the normal configuration of your chest is going to impact the functional aspects of the heart. Now let's move on and let's talk now about looking at the skin. The skin can give us a great look at basically the perfusion, the oxygenation of the blood. Okay? And we can get a lot of different things, or we can look for a lot of different things just simply by looking at the skin. Cyanosis is one of the first things. So cyanosis, by definition, is kind of this bluish discoloration that occurs. And it comes in two different flavors, where you have peripheral and central. Peripheral, this cyanosis is simply due to a perfusion problem. So blood is not getting from point A to point B correctly. There's something wrong that's affecting that delivery, whether it be a blood clot or they are septic, they're sick, and they're just not perfusing their extremities properly. Okay? So this is a blood flow problem. Now compare that to central cyanosis, where instead of now the periphery and your extremities being affected, this is now like things like your lips, your tongue, your mucous membranes. All of those will show this cyanosis. And this is a oxygenation problem. So the blood itself does not carry the amount of oxygen that it should normally. And this is a normal finding in brand new newborns. If anybody has ever had a baby, you'll know when they're first born, they come out looking purplish, right? We talk about APGAR scores, and that's what we're assessing is their coloration. And you'll see as time goes on, and now that that baby is adjusting to breathing air, instead of relying on the placenta attached to the mom to provide that oxygenation, they start to become red, they start to pink up and everything like that. But this is a normal thing in the newborn. Not normal once you're out of that first 10 minutes of birth, okay? It becomes abnormal if somebody has central cyanosis. And again, this is an oxygenation problem. So another thing to look at is pallor. Pallor is something that we normally associate with anemia, where you just don't have the boxcars, the red blood cells, to carry that oxygen around like you should. One of the easiest places that you can evaluate and see if this is going on is looking at the conjunctiva. You pull it down and it looks pallorous. There's not a lot of blood, not a lot of red blood kind of going to that area. And this anemia, especially if it's severe enough, can actually trigger a compensatory reaction to make up for that lack of oxygenation. So if I don't have enough boxcars to deliver the oxygen for every beat of the heart, what can I do? I can increase my beats per minute, right? And now I'm kind of compensating and adjusting to correct or get to a more physiologic, normal oxygenation delivery state. But you can also see that also will trigger your blood pressure to go up as well. Edema. A couple of things to kind of note about edema. If you see equal bilateral lower extremity edema, then be thinking of the heart failing, where it's not delivering and circulating that blood like it should, and things start to back up, and you start to lose like plasma and other fluids out of the bloodstream and into the soft tissues around that area. And when you have somebody who has heart failure, usually that fluid accumulation is going to be wherever it's gravity dependent. So this means like if somebody's walking around and they have heart failure, yes, their legs may be affected by this. But if they're bedbound, they're in the hospital, and they have their legs elevated, the gravity dependent areas now is in like the sacral area, right? So don't be falsely reassured by a patient who is admitted to the hospital with heart failure that the swelling in their legs is getting better. It could be that it just moved down to the sacral area. So you got to check that area for pitting edema. If you have just a unilateral swelling of an extremity, this is typically something to think of like a clot, a blood clot that's affecting that extremity specifically. That return of blood is being impacted. So if it's unilateral, think clot. If it's bilateral, pitting edema, and it's symmetrical, then be thinking of the failed heart. Now there are some other conditions like nephrotic syndrome where you can have that bilateral swelling and symmetrical swelling and some other things, even hypothyroidism when you start talking about endocrine and the thyroid disorders. One of the symptoms of hypothyroidism is swelling. So it could be indicative of that as well. Clubbing is another term. You can see the changes to the fingernail beds in this picture. This is something that is chronic. This is not an acute finding. So this is not somebody who just develops pneumonia, all of a sudden is going to have this. This is going to be a chronic condition. So COPD is a great example where the condition itself is chronic, it's over time, but it limits the oxygenation so that you see these chronic changes start to develop, and you see kind of the curvature of the fingernail bed is changed. Now, jugular venous pulsations is another part to our inspection, and when we look at the jugular venous pulsation waves, what we're looking at is we're getting a rough estimate of what the pressure looks like in the right atria. Okay, there between the right atria and the jugular vein, there is no valves. So whatever pressure is in the right atria is going to be in the jugular vein. So this is why we look at the jugular vein to kind of determine and see different pathologies. And jugular venous pulsations cannot be confused with jugular venous distension. Those are two different conditions. The distension version of this is that pressure exceeds the normal, and now it's pathologic. So jugular venous pulsation, it can be normal, and we can appreciate that finding in any patient of ours. It's only jugular venous distension when it exceeds a certain pressure, and now it's pathologic. Okay, so don't confuse the two terms. How do you get the jugular venous pulsation or measure it? Well, you got to put the bed between 30 to 45 degrees. You got to have the patient look to their left, and then you got to observe the jugular vein and the pulsation wave, usually with the use of like a flashlight to kind of get that parallel, kind of to help you kind of see that pulsation wave. Then you got to measure where is it above the sternal notch, and then add 5 centimeters, and then that gives you your jugular venous pulsation wave height. And that value should be about what the pressure is in the right atrium. Okay? So it can give you a lot of information. But if that centimeter height exceeds 10 centimeters, then this is jugular venous distension. Okay? Now it's pathologic. It should be normally anywhere from 6 to 8 centimeters, so barely seeing that pulsation wave to, still pretty low, only about 3 centimeters up from the sternal notch is normal. Once you exceed 5, or you get to 5 centimeters above the sternal notch, now you have jugular venous distension, and this is pathologic for a elevated pressure in the right atria, which typically we associate with fluid overload or heart failure. Okay? So jugular venous pulsation does not equal jugular venous distension, but when that pulsation wave exceeds 10 centimeters, then it is jugular venous distension and pathologic. But when we look at the jugular venous pulsation wave, it's not just a peak in a valley. There's actually kind of this rhythm to it, and it has this little waveform to it. And what's interesting is when we look at this waveform, I can tell what's going on in the cardiac cycle. And you can see that on this page here, where this A wave is the highest pressure in the right atrium. When do you have the highest pressure in the right atrium? When it's squeezing, right? So it's actually diastole. because the squeeze of the right atria is diastole. So this corresponds to your P wave on your EKG, right? You get that squeeze of the atria, it rapidly increases the pressure in the right atria, so you can kind of get as much of that blood out of the right atrium into the right ventricle before systole starts and sends it up to the lungs, right? And you can see, okay, I'm peaking, I'm squeezing. I get to the point where now I start to lose my pressure. I start to get that relaxation of the atria. The pressure starts to drop. And then all of a sudden you see the in this case, the tricuspid valve closes immediately before the C wave. And you can see the C wave here, it kind of dips up really quick and then goes back down. That C wave is actually the tricuspid valve has closed, but now because of that increasing pressure in the right ventricle, it kind of causes that valve to kind of billow a little bit back up into the right atria. So you just see that little tiny increase in the pressure in the right atria from that valve billowing up. It doesn't open, or shouldn't open, but it just billows up a little bit and increases that pressure. But the pressure, the atria is going to continue to relax, and you see that pressure dropping until you get to that X descent, which is the atria is fully relaxed. Now that passive venous return begins, and now pressure or volume starts to get to the right atria, so the pressure starts to slowly rise until you're at the end of systole, and you get the closure of the aortic valve, the pulmonic valve, so we're on the right side of the heart. You get the closure of the pulmonic valve, and then you're accumulating more and more volume, but that tricuspid valve is closed still. Okay, there's a slight delay with the closing of the pulmonic valve and the opening of the tricuspid valve. Okay, it's milliseconds, so it's hard for us to be able to appreciate it, but it is there. In that time where the right atria is maximally filled, immediately before that tricuspid valve opens is now your V wave. Okay. Then that tricuspid valve opens. I start dumping all of that volume passively from the right atria into the right atria into the right ventricle, and you start to see that pressure coming down into the Y descent here, and then we get the atrial kick again, and now the pressure goes back up, and now we've completely started the cardiac cycle over again. Okay. And the reason we talk about the jugular venous pulsation wave is if we have a distortion or a change to this, I can actually get a good understanding of what the pathology is in that patient's heart. I don't expect you to memorize this chart for our first block test. As we are talking about the different pathologies over the 4 blocks, we will say you lose the Y descent, or you lose the A descent, or whatever. And you'll see, we'll talk about most of these conditions and the effects on the different waves and descents, but don't, for this test, memorize this chart. We will talk about it. The only thing that I might ask you about is the A wave. So we said the A wave is from the atrial kick, right? What condition causes a loss of your atrial kick? We've studied about it in EKG. AFib, correct. So if you have atrial fibrillation, you lose the A wave. So on your jugular venous pulsation waveform, you're not going to see that A wave. You may see all the other waves, but you're not going to see that A wave. And that can tell you just simply by loss of the A wave, this patient has AFib, even before I've done an EKG or auscultated or palpated the heartbeat. Okay. So continuing on with our physical exam, in our inspection part, is a sign called Kussmaul's sign. Okay. So normally, when I take a deep breath in, I'm increasing the venous return to the right atrium, right? I create that negative intrathoracic pressure. Now I have higher pressures in my extremities. That's going to send the blood rushing back to the right atria and to the right ventricle. So normally, your jugular venous pulsation wave, when you inhale, should drop a little bit. Okay, because everything is going back to the heart. Easier. When I have Kussmaul's sign, though, what ends up happening is, as I take that deep breath in and I start to create that negative intrathoracic pressure, now I'm increasing that venous return. If I have a heart that cannot accommodate that extra volume, it's going to back up. It's going to back up into the jugular vein, and I'm actually going to then see that waveform go up. That is a Kussmaul's sign. That's a positive Kussmaul sign, is the rising of that jugular venous pulsation wave with inspiration. Okay? Does that make sense? Why that happens pathophysiologically? And when you see this, it's because there's a problem with the right ventricle. The ventricle is the problem. It doesn't want to accommodate all that extra venous return that's coming because of that inspiration or that negative intrathoracic pressure. So you'll see that waveform go up because it backs up. Now another thing is the hepatojugular reflux. This is accomplished by pressing up underneath the right side of the rib cage on the liver. And what you're doing is you're trying to force blood to return from the lower body back up to the heart. So you're kind of thinking of the, instead of the negative intrathoracic pressure drawing all that blood back, now I'm forcing that with positive pressure on the abdomen to try to force that blood back up. Well, if I have a heart, especially a right-sided heart problem, where I can't accommodate all that extra volume by pressing on the right upper quadrant and increasing that blood return from the abdomen, it's going to back up into the right jugular vein because the heart has a problem and it can't accommodate that extra volume return. And that is what's called the hepatojugular reflex, and is typically seen in states of volume overload where that heart just cannot function, it cannot keep up with that volume, and it starts to back up in the other organ systems. So, okay, that was inspection. Any questions about inspection before we move on to palpation? So palpation, there's a lot of things that we can do with palpation that give us a lot of additional information. When we talk about PMI, or point of maximal impulse, this is simply done by using the heel of our hand, and we kind of put some gentle pressure over the patient's left lower chest wall and around the 4th or 5th intercostal space, and that should be the apex of the left ventricle. Okay, so what you should feel if you're pressing on the apex is you should feel that squeeze hitting your hand, and that tells you where it should be. It should be in like the mid-clavicular line. If I palpate it and it's not in the mid-clavicular line and it's deviated to the left or to the right, this actually now tells me that the orientation of the heart, or the orientation of the center of the mass of the heart, is disrupted from normal. So if I have a condition that causes left ventricular hypertrophy, now what I'm going to see is that PMI is going to be displaced to the left. If I have right ventricular hypertrophy, I'm going to see that deviated to the right. So you can get a lot of information just actually by palpating where you feel that beat of the heart. There are some additional findings with the PMI. So if you have hyperdynamic, meaning that it's moving around on you, then that could indicate a volume overload, which you may hear like an S3 on auscultation if this word would be present in your patient. If you have a pressure overload, you may hear an S4 on auscultation. But you're going to see that actually that impulse is going to last longer than normal because it's having to squeeze much harder, much longer in order to get that blood flow out of the heart. Okay. And then also with palpation, you can appreciate a thrill, which is kind of like a vibratory sensation. Typically, you're going to see these in folks who have heart murmurs, systolic heart murmurs, that you grade greater than 4, like 4, greater than 4 out of 6. Usually, you're going to actually be able to feel this vibratory kind of sensation, this hum kind of thing. And then heave or lift is something that if the heart's having to squeeze harder against a lot of pressure, you're going to feel that sustained kind of squeeze, or it's going to have to kind of put some extra oomph into the squeeze in order to get that blood circulating. And then when we look at blood pressure, yes, we have to use the blood pressure monitor, the sphygmomanometer, right? But there should be symmetry between the left and the right and the upper extremity and the lower extremities. It should be symmetrical. We're going to talk about some disorders where this is not symmetrical when we talk about our congenital heart disease on Friday, but it should be symmetrical. You can also get a pulse pressure, which is the difference between your systolic and your diastolic. So you just take your systolic, subtract the diastolic from that, and that gives you your pulse pressure. That should be about 30 to 40 millimeters of mercury. Okay, that's a normal pulse pressure. When I have it higher than 40, this is indicative of a condition where I have to generate a much more powerful squeeze in order to get the blood circulating. So my systolics are going to rapidly go up, but my diastolic may actually drop. So now that difference between my systolic and my diastolic kind of widens, and that is something that we see in like aortic regurgitation. Okay, so when you have a valvular disease of aortic regurgitation, you can see that increased pulse pressure. Now, if I see the opposite, where now that pulse pressure is less than 30, this may be indicative of like dehydration or hypovolemia, where I can't support a high enough systolic, but the tone of the blood vessel is enough to kind of keep the diastolic up a little bit, okay? So narrow pulse pressure usually is hypovolemia, like dehydration. And then there is, of course, palpating of the pulse itself. Again, the pulse is not just a single wave and that's done. It actually has like a little dip to it, but then it comes back up and then dips down again. That is what a normal pulse is going to feel like. And when you palpate a pulse, it's more than, yes, it's there, no, it's not. It's what trauma would make you think of, right? Is pulse present or not, right? But there's actually a lot more information you can get from that pulse. What's the strength of it, right? Normal is 2+, right? What's the rate of it? We check the pulse to get the rate, right? How fast are we going or how slow are we going? What's the rhythm? Is it regular or irregular? Is this patient an AFib or not? And then I can also palpate, the left side and the right side to make sure that those pulses are symmetrical. There's going to be conditions that we're going to talk about where it's not symmetrical, and that could be one of the initial findings that makes us suspicious for pathology. Questions on palpation before we start auscultation? Auscultation is probably going to be the bread and butter of the provider because this is what we're going to do on every single patient that we see. Even if they're coming in for knee pain, you should be listening to their heart and their lungs. And when we talk about auscultation, it can be done in 3 different positions. So you can do it sitting, you can do it supine, and you can do it in the left lateral decubitus position. And we're going to talk about why these 3 things are important over the course of the next couple of slides. But you have normal heart sounds, which is your S1, S2, and then you have abnormal heart sounds, which could be things like S3, S4, opening snaps, ejection clicks, and then you have your murmurs. Now you can see there's a difference between heart sounds and murmurs. And we're going to talk about what makes one thing a heart sound and what makes one thing a heart murmur. When you go to auscultate, recall that there are 5 auscultation sites. You have your aortic auscultation site, which is in the right upper sternal border, right? Then you have your pulmonic auscultation site, which is your left upper sternal border. Then you have Erb's point, which is your left sternal border. Then you have your tricuspid, which is your left lower sternal border. And then you have your mitral area, which is kind of in the mid-clavicular area. And if you're having problems kind of remembering where each of these things are, just remember APTM, compartment M, as far as how you, the different sites. Just throw in Erb's point for the left sternal border there between 2 and 4. Or sorry, between the pulmonic and the tricuspid valve. Okay. And we'll talk about what types of murmurs you hear in these different sites when we start talking about the murmurs. But just remember, there are these 5 auscultation sites. When you go to auscultate and you have the stethoscope, you've got to have a stethoscope to do a proper evaluation. You have to have a stethoscope that has both a diaphragm and a bell. Okay. I know they've taught you in other classes that you can just use a bell by light palpation of the thing on the chest wall, and then the diaphragm is hard, like a little harder press onto the chest skin. That is only with certain stethoscopes, okay? So if you go and get a stethoscope, look at the user manual and see if you can use it that way. Otherwise, you have to do it this way, where you have the 2 sides, and then you just rotate the head of the stethoscope to do bell versus diaphragm, okay? So just be careful what kind of stethoscope you get, because it may not be a bell with light palpation. It may still be a diaphragm thing. And why is that important to know? Well, if I am suspicious or suspect a high-pitched heart sound or a high-pitched murmur, then I want to use the diaphragm portion of it. The diaphragm allows you to auscultate and appreciate the high-pitched frequency sounds. Okay? The bell does the opposite. It looks for low-pitched sounds. And so if you're using a diaphragm only, you may miss things like an S3 or an S4 by not using the bell, because you're not appreciating or listening in the lower frequencies, okay? So make sure you're using the bell and the diaphragm for your physical exams. And when it comes time to auscultating, before you really do anything, there's 3 questions you have to ask yourself. Where is my stethoscope? So which auscultation site am I listening to? I need to ask, am I using the diaphragm or the bell? Am I using a high-pitched or low-pitched frequency thing? And then, is the sound I'm hearing, is it occurring during systole or is it occurring during diastole? Okay, because if you can answer these 3 questions, you can diagnose the patient even without the echocardiogram to tell you what's going on. So kind of going back to using your physical exam to come up with a good, reasonable diagnosis, and then ancillary studies to confirm that diagnosis. So this is a normal heart sound, okay? Your S1 or your lub, it is the closure of your mitral and your tricuspid valve. Remember, in a normal heart, you should not hear an opening of the heart valve. And when you're listening to it, you hear a very distinct lub-dub, 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 lub-dub. Okay, can you hear that? It's maybe a little hard to hear it on the overhead speakers. When we come back in 2 weeks and do our lab, we will actually use our infrared stethoscopes, and you're going to hear these heart sounds, and it's going to be so much easier to hear this, okay? It's hard over the overhead speakers to hear some of these subtle findings. So don't be concerned if you don't hear abnormal stuff, okay? So the S1, the lub, is the closure of the mitral and the tricuspid valve. It is a high-pitched frequency, so that means the diaphragm of the stethoscope is the best head of the stethoscope to use to hear the S1. Because S1 is a closure of the mitral valve, it is best heard by listening over the mitral auscultation site, right? There's more pressure on the left side, more pressure to close that mitral valve compared to the tricuspid valve on the right. So it's best heard, S1 is best heard over the mitral auscultation site. Now compare that to S2, which is basically the same audio file. It's just now instead of focusing on that lub, you're listening to the dub part. Okay? This is also high-pitched, but this is best heard in the pulmonic auscultation site, so the second to third left intercostal space. And the dub represents the closure of your aortic and pulmonic valve. Okay? So this is the start of diastole. And you may be wondering, well, we just said the mitral area is the best place to listen to the. Sorry, let me stop. Okay. So we just said the mitral area is the best place to hear the S1 because of the higher pressure. Why isn't the S2 best heard over the aortic? And the reason for it is you may miss the evaluation of physiologic splitting of the S2, which is something you hear here on this next slide. So remember, S1, S2 is lub-dub, but listen to this version. Instead of a distinct dub, it's kind of a lub-ba-dub, lub-ba-dub, lub-ba-dub. And we see this actually in the setting of breathing. Okay? Go forward and stop that. Okay. So we see that with breathing. And what happens is, as I take that deep breath in, I'm increasing that venous return to the right side of the heart, which means now that right side is experiencing higher pressures than normal. So that means I have to generate a higher pressure in order to get blood circulating. And to get all that extra volume out, I'm delaying that closure of the pulmonic valve, which you can kind of see on this chart down here. Okay, so the pulmonic valve closes. Let's see right here. So the pulmonic valve closes later than normal, but another thing is happening over on the aortic side, where because I'm inspiring and I'm having that negative intrathoracic pressure, that pulmonary vasculature wants to hold on to that blood, okay? So what's happening is then even though I'm increasing my venous return to the right side, I'm decreasing that venous return to the left side. So now I have less volume on the left side, which means I have less volume to squeeze out of the left side during systole. So I can't keep a pressure high enough to keep that aortic valve open. So what you see is that aortic valve closes earlier, and you see that difference of earlier aortic valve and later pulmonic valve closing, and that's what splits the S2. And that's what physiologic splitting of the S2 is. Okay. Let's go ahead and take 10 minutes and come back at 2:02, since I took 2 minutes.
Looks like I'm the office. Do the same.
bring it in for our EKG lab. I got the Echo stethoscope. No, it's for something. I didn't try it. My wife.
That's like a graduation gift. I didn't ask for it.
So.
Oh, okay. I was like, damn, that's a whole movie. God.
She can't do long way.
Oh my God.
Yeah.
I feel myself. That's what it's not right.
Oh, yeah. Yes. They don't do that.
What do you call me that? I almost made that. Cars. That cover coat. No,
Oh yeah. And the way I don't wait 8 hours a day. You get one like but it's 8 hours. Isn't it or her back end like I feel like my I feel like I'm like I feel like this right here, I feel like I'm doing this back like it hurt my tummy. And I'm always trying to like extend more out, but like it's like a fucking long ass legs. Yeah, the chairs are nice. I really appreciate the chairs. How does this look like this? I killed the shag. So this is when they ask yeah, they ask him what's the reason of your song and under pressure like there goes song goes dun 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 and he goes dun 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 they didn't want to give he didn't want to give copyright to Queen. So oh yeah, it's awesome. That's awesome. Done. But we go dun 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 dun.
Ding, 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 ding. This one? Nah, we changed it a little bit.
Yeah. Well, yeah, I forgot to take Oh, really? Hell yeah.
I mean, you can do most of those like two times if you want to. I think we should found that. Full sense.
Ready, I've got 14:02 on the clock. Get back to it. So if you're having problems hearing, we're going to hear a lot more examples of abnormal heart sounds and murmurs and stuff. But if you're having difficulty hearing that, let's listen to Vanilla Ice to tell us where what to do, if it's different or not.
Anything like that. And just to prove his point, Vanilla breaks it down and sings the dings. Ding 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 ding. Ding 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 ding. Ding ding ding. That's the way theirs goes. Ours goes ding 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 ding. Ding 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 ding. That little bitty change. It's not the same. Ours goes ding 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 ding. Theirs goes. Ours goes. Little bitty change. It's not the same. Not the same. Not the same. It's not the same.
So it's not the same. And
Get sued for
so you hear the different heart sounds, they are not the same. So, when I first started lecturing this, I was talking with my mother, who both my parents are classical musicians, and My mom played church organ for like 60 years, was classically trained and everything like that. And I was playing it, she was like, oh, yeah, I can hear the difference with the Vanilla Ice clip here. So with experience, you can learn to differentiate the difference between subtleties. So hopefully that will be the case when you're listening to heart murmurs. So, okay. So we just finished talking about physiologic splitting of the S2. Okay, we talked about how the reason this happens physiologically is with inspiration, you delay the closure of the pulmonic valve, and the aortic valve closes sooner. Okay. Well, that's physiologic splitting of the S2. You may notice a fixed splitting or some other variation of that split S2, and that is not physiologic. It actually could mean there's a lot of different pathologies that you can kind of see on this slide. This is FYI for this lab, or this lecture, or this block. But you can see different pathologies can cause a difference in that splitting of the S2. And it is not physiologic. So you can have physiologic normal, and you can have pathologic splitting of the S2. So now let's listen to abnormal heart sounds. And the first one is the S3. Here's an example of it. Turn up the volume a little bit. Kind of hard to hear it. But instead of it being a lub-dub, it's a lub-ba-dub. Lub-ba-dub. When you hear this exact sound when we are in our lab listening using the infrared stethoscopes, you'll hear it, okay? But in this classroom setting, I can't even hear it. It sounds like a lub-dub to me, but it actually is a lub-ba-dub.
That's cool.
If you want to, before our lab, you can put headphones in and listen using the PowerPoint, and you may actually hear it better than what you hear it here. But it's not that. Yeah.
How do you feel about the uprising of technology in medicine and using that to our advantage?
Yeah.
Some of the old school providers are kind of against it.
I think as a society, a modern society, we're becoming more and more reliant on technology to help us, that we are losing a lot of these skills. And like that stethoscope that I showed you, one, it's got a volume control, which is always great, because when we start losing our hearing, we may start to lose that ability to detect those subtle findings. So that stethoscope does have a volume control. But using AI can actually detect that heart murmur and then can alert us to that. Even before, I mean, it maybe is just a subtle finding and maybe early pathology, we can catch it early so that we can intervene and prevent it from getting worse to the point where you can hear it easily. Yeah. I'm pro-technology. I don't think AI will ever fully replace the medical provider. I think it's too complex and can't do physical exams and those kinds of things, but there definitely is room for technology in our practice. Unfortunately, what's the biggest thing with healthcare right now? It's affordability, right? What is technology and using more technology in our practice going to do? Jack the price up, right? Granted, it also may lower our malpractice lawsuits, but it's different pots of money that pay for that. So let's see. Okay, so S3. So when we talk about S1, S2, we talk about those being high-pitched heart sounds. So we would want to use the diaphragm to listen to those sounds. But look at the S3. It's a low-pitched, low-frequency heart sound. So to be able to actually appreciate the S3, you have to use the bell of the stethoscope. And it actually is best heard if we do the left lateral decubitus position. So put them on their side, their left side down, and then listen there. That's the best way to hear an S3. And remember when we talk about no murmurs, rubs, or gallops, the S3 and the S4 are the gallops that we're talking about, okay? The S3 is known as a ventricular gallop, and it's normally a heart sound that we see in a volume overloaded state. So this is somebody with heart failure, so volume overload. So somebody with heart failure, you may appreciate this S3. Okay. Now compare this to the S4. So this is early diastole, right? Listen to the S4, which is late diastole. Again, overhead speakers here in the classroom, it sounds lub-dub. But it's actually a ba-lub-dub. 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 And what causes this, so this is also known as an atrial gallop, but what's causing this is a pressure overload state where the ventricle is stiff, it's non-compliant. So when the atria squeezes during the atria kick and it starts sending this rapid stream of blood into the ventricle, instead of that left ventricle dilating and accommodating that blood, it's running into a brick wall. That's your S4. Just every time the atria squeezes, you're just hearing that blood hitting the wall. So it's not going to accommodate it. Okay. So that's why you hear this in late diastole, because remember the atrial kick is the last portion of diastole before that ventricle starts to squeeze and you get that S1, okay, and the start of systole. Also know about S4 is it also is low frequency. It is best heard at the apex, because where is that running into the brick wall happening from the left atria when it squeezes? It's right there at like the mitral auscultation site, right? So best heard at the apex with the bell of the stethoscope due to it being a low pitch, low frequency heart sound. Okay, so if you like tables to do compare and contrast, here is a table that shows you what an S3 is and what an S4 is and why they are different. Okay. So just an extra little study tool. This one you can hear. You hear it? Okay, it's like a love, 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 love. It's kind of what you hear it. So this is, and you can kind of see on the graphic there, kind of the configuration of what that sound is like. Let me just stop that. But this is a ejection click. Clicks are systolic, okay? Clicks are systolic, they're always systolic. And when it happens early in systole, we normally are thinking of a stenosis of like the aortic valve or the pulmonic valve, a resistance to opening. Okay. When it occurs middle or late systole, now we're thinking of a condition called mitral valve prolapse. Okay. And we'll talk about a lot of these kind of conditions, these valvular conditions in block 3. So you may in block 1 just kind of have to hit the I believe button and not understand the context of these valvular diseases. We will come back and review all of this in depth, actually over the course of 2 lectures, the different valvular diseases. So hopefully then it will kind of make sense why we hear these things. But for block 1, just learning the different heart sounds, what they are, where you hear them, and like the different murmurs when we talk about that. And then we'll revisit the valvular diseases come block 3. Okay, so that is an ejection click. So I said ejection clicks are always systolic. Well, if we have a systolic version, we must have a diastolic version. A systolic or diastolic version is called an opening snap. So snaps are diastolic. And you can hear it, kind of the configuration. There's a murmur associated with this. But opening snaps are diastolic and they're high pitched, so diaphragm of the stethoscope in order to hear it. And is typically associated with like a mitral stenosis. The mitral valve, let me stop it. The mitral valve should be opening during diastole, right? But if there's a resistance to opening a stenosis of opening that valve, you then are going to have a delay. You're going to hear this extra sound, and that's the opening snap. Okay. So opening snaps are diastolic, clicks are systolic. And if you want to see the difference of all the different types of sounds, heart sounds, here's just a table comparing those. Okay. So we already watched that part. So, how does this interplay? What is physiologically going on in the heart? What are we hearing? How do these all tie together? Because we have to auscultate, right? We have to palpate. We also can use our EKG. How do we mix all of that data to actually understand what's going on in the heart? And this graphic kind of summarizes that. Granted, it's looking at what's going on the left side of the heart, okay? So just know that it's going to be a little different on the right side, particularly the pressures are going to be lower on the right side compared to the left. But you can see the timing of what's happening in that cardiac cycle, why you hear what you hear when you hear it, what's going on in your EKG that's causing that physiologic response. All of that is summarized on this slide. So we're going to start here. So the blue line is your pressure in your ventricle. The grayish line down here is the pressure in your atria, your left atria. This gray line up here is the pressure in your aorta. The red line is the volume of blood in the ventricle. And then, of course, your EKG. And here's your auscultation sound, okay? So we're going to start here where it says mitral valve closes, okay? So now you can see that pressure of the ventricle equals the pressure of the atria, right? Maybe slightly above to close that mitral valve. Well, what's happening? You see the volume is up here, but you can see it's kind of correlating with your QRS. So you're getting depolarization of your ventricle. What is depolarization of the ventricle doing? It's causing a squeeze, right? So that pressure is increasing in the ventricle above that of the atria pressure, so it's closing the mitral valve. That closing, remember we hear, on a normal heart we should hear closing of valves. That mitral valve closing, we are appreciating with auscultation as your S1. Okay. Well, you can see the pressure of the atria is down here and the pressure of the aorta is here. This is your afterload up here, right? As the ventricle starts to squeeze, it's squeezing, the pressure is rapidly increasing. But what's going on with the volume in the heart or in the left ventricle? It's staying the same because the aortic valve is still closed. Blood is not flowing, okay? That pressure rapidly increases until it gets to that threshold where it exceeds your afterload, and now you get that aortic valve open. Now you can see that pressure remains above the aortic pressure, so that valve remains open, and your volume is rapidly dropping because now you're moving blood out of the left ventricle and into the aorta. And you can see when you compare that to your EKG, you're kind of in that ST segment period of time, okay? Now, that ST segment then moves into the T wave, which what's going on with the ventricle in the T wave? Repolarization, relaxation, right? So if I'm relaxing, I can't maintain a pressure. But I'm also losing a lot of volume, so that's going to make it a little more difficult to keep that pressure up, losing all that volume. And then you get to the point where now the ventricle cannot keep up with the pressure of the aorta, and you get the closure of the aortic valve, which corresponds to your S2. And this occurs towards the end of your T wave, okay? Now that pressure as the ventricle starts to relax, starts to drop rapidly, but you can still see the volume's not changing at all because that mitral valve is closed still, okay? That pressure continues to drop until you get to the point where now that ventricular pressure is just under the atrial pressure, and now that mitral valve opens. And now you start to get the diastole, that passive flow of blood from the atria and into the ventricle, and your volume rapidly increases. And then it kind of starts to kind of peter out a little bit, and then your atrial kick or your P wave comes in. You can see your P wave down here on your EKG. It then rapidly increases that pressure a little bit, and you get additional flow, additional volume into your right or your left ventricle before that cardiac cycle starts all over again. Now, when you look at what's going on in the pressures of the left atria, you can see it's kind of towards the middle of your P wave, right? Remember, have you guys talked about in your EKG class yet, the P wave, and how the first part of the P wave is your right atrial squeeze and the last part is your left atrial squeeze, right? So because we're talking about the left side of the heart, that rapid pressure increase of the left atria is going to be delayed to the middle of your P wave, okay? Does this make sense? This ties everything that we've just talked about physiologically, what's going on, what we're hearing, what we're seeing on our EKG and everything like that, ties it into show you how the timing of all of this occurs in a normal cardiac cycle. Okay. It's more than just lub-dub. There's more to it. That's why this study of the heart is so difficult to truly understand, because there is so much going on in just that period of time between a lub and a dub. Okay. But it's vital, because without it, you're dead, right? So you gotta know this. Okay, so let's move on, and let's now start talking about murmurs. So remember, we talked about heart sounds are different from murmurs. They're two separate entities. And the reason for it is what's causing the murmur. The murmur is due to one of three things. Either you have abnormal blood flow across a normal structure. So an instance of that would be anemia. Anemia, reduced red blood cells, reduces viscosity, which increases speed. So now you're having a much faster flow of blood across a normal heart structure. Okay? That causes a murmur. You can have a normal blood flow across an abnormal cardiac structure. Okay? So I have a stenosis, a calcification buildup on one of the heart valves, and now there's a resistance to opening and a resistance of flow. So now I'm hearing that turbulent blood flow kind of occurring because it's hitting something and then kind of skewing off to the side instead of having that unidirectional flow like it should have. Okay? So normal blood flow across an abnormal cardiac structure. And then the third cause of heart murmurs we're going to talk about on Friday, which is like an abnormal shunting of blood, where instead of blood going from the right side up through the lungs and then down to the left side, there's something communicating the right and left sides abnormally, and that will cause a murmur. And we'll talk about the different types of murmurs based on the different types of congenital heart diseases on Friday. Okay? But when you listen and you hear a murmur, if you have a diastolic murmur, the chances are it's pathologic. It needs to get evaluated right away. If you hear a systolic murmur, it may be pathologic or it may be benign. So you may need to do echocardiograms to evaluate it further, but you may not. Okay? When you listen to a murmur, there's a lot of descriptors that you can actually apply to that murmur. Instead of it just being a murmur heard at the pulmonic auscultation site, There's a lot of things that you can actually add to it. And you can see the list of 1 through 7 as descriptors of that murmur. And we'll go through each one of these and what we're trying to convey with it. So timing and duration. So when does it occur? Systole, diastole, or does it happen continuous, meaning that it happens both in systole and diastole? Okay, so that's the timing and duration of your murmur. Location and radiation, okay? The location part usually is difficult to understand, but when you break it down to what types of murmurs you hear in the different auscultation sites, it actually kind of makes a little more sense, and it's actually a lot easier, and hopefully we can understand that better, because your PACRAT, I know, definitely tests you on heart murmurs. It'll describe a heart murmur, and then you got to know what the valvular disorder is based on the description of that murmur. And that also then means the PANTS. It's going to have a lot of questions on just heart murmurs, and you have to be able to diagnose based on the description of the heart murmur, particularly is it systole, diastole. They'll say crescendo, decrescendo, but they'll give you the location of the murmur. And hopefully, this slide will help you understand what murmur is present based on the location described for that murmur. Okay. So let's start looking at the aortic and the pulmonic areas, okay? If you notice, what timing of murmur do they only have? Only systolic. So you only best appreciate systolic murmurs in the aortic and the pulmonic valves, auscultation sites, okay? What are those valves supposed to be doing during systole? They're supposed to be open, right? During systole, the aortic and pulmonic valves should be open. Well, a stenotic murmur is a murmur that occurs when that valve should be opened, okay? Regurgitation occurs when that valve should be closed. So, if I only hear systolic murmurs in the aortic and the pulmonic auscultation sites, those valves should be open during systole. That means that the murmur, if I hear it in those sites, is going to be either an aortic stenosis, if I'm listening to the aortic auscultation site, or pulmonic stenosis, if I'm listening to the pulmonic auscultation site. Okay? It's the only murmur you care about in the aortic pulmonic auscultation sites. Well, you may wonder, well, what about the diastolic version of that? Well, I have to go look at a different location to be able to hear a diastolic murmur of the aortic and the pulmonic valves. And to do that, I got to look at the left sternal border. When you look at diastolic murmurs, you see you have aortic regurg, and you have pulmonic regurg. Well, the reason for why the Erb's point, or the left sternal border, is the place to listen for those types of murmurs is, what's the direction of blood if it's regurgitating and coming back into the heart from those valves? It's hitting the interventricular septum. That's where Erb's point is. It's over the interventricular septum. So that's why you hear the pulmonic regurg and aortic regurg going to that location. Okay. We'll talk about systolic murmur of Erb's point at a later date, but just recall the diastolic murmur at Erb's point for now. Now let's look at tricuspid and mitral valve. Okay. So tricuspid area and mitral area, you notice you have holosystolic murmurs, you have diastolic murmurs, and down in the mitral area you have a systolic murmur. Okay, holosystolic means the full duration of systole. Okay, so from S1 to S2 you're hearing murmur. compare that to a systolic murmur where it's not the full duration. So you may have like a very distinct clear S1 and then you hear the murmur, or you may have an obscuring of S1 but you hear the S2 clearly. It's not for the full duration, okay? So let's look at the tricuspid area and let's talk about why we see a holosystolic murmur. What should the tricuspid valve be doing during systole? Should be closed, right? What did we also say is the start of systole, that S1? What is the valve that is closing to trigger S1? Your tricuspid valve and your mitral valve, right? So if I have a regurgitation, so I'm not getting a good, seal of that valve, and I'm having a backwards leak of blood, does it make sense that that murmur is going to start at S1 because that's when that valve should have closed? But because it didn't close, I'm getting a reflux, a regurgitation of that blood back into the atria. Okay. So, and that's going to occur because that pressure in that ventricle is going to continue to rise, and blood's going to go from path of least resistance. So it's going to want to continue to go from the ventricle into the atria because that pressure in the atria is always going to be less than, on this side, the pulmonic artery, right? It gets to a point where you're going to get some flow up to the pulmonic artery. 100% of that blood's not going to go back up into the right atria, but a large portion, or depending on how severe that regurgitation is, a good portion of that blood volume could go back into the atria because of that regurgitation. Okay? So that's why tricuspid regurgitation has a holosystolic murmur. Same goes with the mitral area. A holosystolic murmur of the mitral area is mitral regurgitation because the mitral valve should be doing the exact same thing as the tricuspid valve. It should be closing, triggering my S1, but because there's something wrong with the valve and I don't get a good closure of the valve, then blood's going to reflux through that valve, starting at S1 and go for the full duration until S2 occurs and you stop getting that flow of blood out of the ventricle. So that's holosystolic. Now let's look at the diastolic murmurs. So what should the tricuspid valve be doing during diastole? Should be opening, right? You need to get that flow of blood from the atria into the ventricle by going through the tricuspid valve. So if I hear a murmur, a diastolic murmur at the tricuspid auscultation site, and that valve should be open, then I have tricuspid stenosis. Okay? Because I have that resistance to opening of that heart valve. Same goes with the mitral area, or the mitral valve. If I have a diastolic murmur, then I have mitral stenosis. You can see just that valve murmur is going to be located at that auscultation site, just knowing holosystolic, systolic, diastolic. And then the mitral valve wants to be a little more complex, and instead of a holosystolic murmur, you can have just a systolic murmur, which is mitral valve prolapse. And we'll talk about during block 3 why we see mitral valve prolapse causing a systolic murmur instead of a holosystolic murmur. Okay, but just for the time being, let's just hit the I believe button on that. Okay. We will go over this during our lab. We're going to go pretty in depth for it, so hopefully you'll understand this because this is probably one of the most important things that you learn during cardio, because you will be tested on this on your standardized tests. Okay. One other thing I wanted to highlight on this slide was the radiation. So If you have mitral regurg, which we said mitral regurg is a holosystolic murmur, what's the flow of that regurgitation? Remember, left atria is twisted and tilted back, right? It's going to the axilla, left axilla. So the flow, the direction of flow of a mitral regurgitation is going towards your left axilla. So if you were to happen to put your stethoscope over the left axilla, you actually will hear that murmur radiating into that direction, because that's the flow of blood. That's the direction of the flow of blood. Okay. Compare that to the aortic stenosis. Aortic stenosis, resistance of opening of the aortic valve. That turbulent blood flow direction is going to be going up towards the aorta and to the carotids. So you can actually hear that murmur by listening over the carotid artery, because that's the direction of flow, that turbulent blood flow. Okay? So those are kind of some key radiation of murmurs that you may see in a description of the heart murmur on your standardized tests, and even on our tests for this class. Okay. I know that's a lot of information. Questions about that?
Yes, sir. So when we osculate, we will be able to differentiate between the holocystic systolic murmur and diastolic murmur?
You should. Mm-hmm. Yeah. It's going to take some practice. Part of it is determining, based on where you're listening, is the S1 louder or S2 louder? The other way, and we're going to talk about it in our lab, other ways that you can do it. So part of it could be like you're palpating the pulse and listening at the same time. And listening, is that murmur occurring during the pulse or during the rest part of that pulse? That can help you differentiate a systolic versus a diastolic murmur. But you can determine an S1, S2, which will help you determine, is this systolic or diastolic? So continuing on our description of a murmur. So intensity means how loud, okay? Systolic murmurs are graded 1 through 6. If you look at what 6 means, it means audible without a stethoscope. This is the person you're sitting next to them and you're hearing their heart beat. Probably not a great thing to be able to hear somebody's heartbeat sitting next to them, right? But systolic murmurs are graded 1 to 6. Diastolic murmurs have to be a little difficult. They can't agree with systolic, and they are graded only by 1 through 4. Okay, so diastolics 1 through 4, systolics 1 through 6. Pitch. This is your frequency. So high frequency versus low frequency. I think we hit that one enough. Quality is going to be like, what does it sound like? Is it harsh? Is it blowing? Is it rumbling? Is it a hum? Those are all descriptors that you can throw in on your murmur, and you may see on your standardized test those things added to the description of the murmur. Then you have the configuration or shape, which is crescendo, decrescendo. This is telling you over time, is that murmur getting louder, gradually getting louder, or is it getting softer? So you may hear it really loud at the beginning and then it kind of peters out. Or you may hear it where it's very soft and then it gets louder and softer. And you can throw in these different crescendo meaning building intensity, so it's getting louder. Decrescendo meaning it's getting softer. Okay. So crescendo, decrescendo, you can see this diamond pattern. That's a typical configuration of a crescendo, decrescendo pattern. A holosystolic or pansystolic is over time, it does not change its intensity. Okay. Now, here's a couple of different murmurs to listen to. We'll see if we can appreciate these. But let's see, this is an example of an early systolic murmur. So in this, look to see if you hear an obscuring of the S1. The S1 should not be a clear, definitive lub sound. Do you hear that? Now compare that to a mid-systolic murmur, which means that you should hear a clear lub, but you should also hear a clear dub as well. Now, this is a late systolic murmur. Now, this one you should hear a clear lub, but the dub should be somewhat obscured. So the murmur kind of distorts that dub, so it doesn't sound normal. And then this is a holosystolic, which means S1 and S2 are going to be obscured. And then here's a diastolic with an opening snap. And this one is also happens to be a decrescendo crescendo, so it gets softer, then gets louder. So just some examples of different murmurs and such. So, okay. Confused?
Yep.
Okay. Now to add on to it,
Great.
to add more confusion is you may not be able to determine the exact murmur just simply by auscultation. So you can do some what are called dynamic maneuvers to help you differentiate the different murmurs. Okay? Dynamic maneuvers is basically things that we can do that will change your preload and or your afterload. And what changing those two variables is going to do to the murmur, okay? So, for instance, inspiration. We talked about how you increase venous return. What that does is that increases the volume of blood coming to the right side of the heart. So does it make sense that if I have a right-sided heart murmur, if I take a deep breath in, it's going to make that murmur louder? Okay, that's a dynamic auscultation maneuver. So inspiration. I'm increasing my preload. Okay. Compare that to standing, which standing decreases my venous return or decreases my preload. So what ends up happening is I'm not getting a large amount of volume of blood coming back to my heart because it wants to pool in my legs because of gravity. This is going to make some heart murmurs louder, particularly in situations of like mitral valve prolapse and hypertrophic obstructive cardiomyopathy, which we'll talk about both of those conditions actually in block 3. So again, let's hit the I believe button. That standing makes these two murmurs worse. We'll talk about why in block 3. Valsalva has a similar effect to standing. So I'm decreasing my preload, but I initially get an increase in my afterload, and then it decreases. Okay. And by doing that, it's going to do the same thing as what standing does, and it's going to enhance the murmurs of mitral valve prolapse and of hypertrophic obstructive cardiomyopathy. Squatting. Now I'm increasing venous return because I'm forcing that blood out of my legs, at least initially, and then I'm also crimping the arteries, so I'm going to increase my afterload. And by increasing my afterload, I'm going to have the opposite of standing in Valsalva, where if I increase my afterload, I'm actually going to make the murmur of mitral valve prolapse or the murmur of hypertrophic obstructive cardiomyopathy quieter. Okay, so it does the opposite from Valsalva and standing. And then there's the hand grip exercise, which is just have them kind of form fists and pull it out. And what this is doing is this is increasing your afterload without really doing anything to the preload. Okay? And when you do this, things like mitral regurgitation, aortic regurgitation, and even mitral stenosis will get louder. aortic stenosis and hypertrophic cardiomyopathy actually get softer. Okay. So that's your dynamic maneuvers. If you like tables, here's your compare and contrast of all those different maneuvers, what the changes are to afterload and preload, and what murmurs you may hear based on changing those two variables. Okay? So that is lecture 2. Do we want to take 10 minutes so I can reset for the next lecture and then jump off, say at 14:54? That'll give you 10 minutes. Okay. So 14:54, we'll kick off with the next lecture.
Honestly,
That is my worst fear. Oh, that is my worst fucking fear, dude.
Your heart is gonna have to send you a thing send up.
She woke up late for the
What?
Oh.
Sure.
Just take it? Did I take it? Okay.
I was louder concentrated.
Oh, that is.
Good are better than fine. Like that part was like.
You need the points. How did you actually get here?
You hold down the fort up here.
Oh, you know, best I can. Not letting the,
Take your spot where
not letting the Trojans
No,
in.
you're not. Better not. I'll take your spot. It would be the first. I was sitting here. Oh, you got bombs. But then she came and took the spot everyone wants. I mean, it wasn't me.
It's called.
I pushed it today.
The test days I've even heard of it. I wasn't doing my hours studying for the test. Like, oh shit, that's weird.
I have 9 years.
I think I forgot which test it was. There was one test where I got here later than my normal testing. I got here like 20 for the test. I forget which test it was.
I think I remember because I usually have it already.
I think it was Psych 1.
I don't know about that. I'm not sure I agree with that. That's better because they yes. That's a lot.
No shots. No, freaking the plug down the road.
We go pill bags,
But that's where they buy them. They buy them in the
pill
shop.
pouches.
So it's like cheap cocaine pouch.
Is that what happened?
People don't sell cocaine in these.
Oh, you know?
No. I wouldn't know, but that would just be sketchy.
They sell damage parts.
The whole thing of selling cocaine is sketchy.
Especially now.
Okay, time for the physical.
The rest was acting like so upset.
Oh, I think the good job. Yeah, right after Rain FM. I did. It's like this motivation, like it's kind of like.
When I get home, I'm gonna take a nap.
Kind of got me into
Text comes out. So you have maybe 120 with it's enough. I mean, if you have your movements, if you're still paying 265 dollars you're at 55.
Does he have a crowd? I used to have maybe 30 minutes, maybe 15. Never take a test with him.
Overall, once for school days, and
one of their best friends.
should be able to are colliding with whatever, especially if should be about 10,000 a month.
Plus, like you're out, like you're out, well, you don't need
Which means $500,000
So I'm hoping it's gonna be more like patient minutes, okay? Rest, deviation,
I would just add another test on Friday. I feel like that would make Friday off.
that's what I'm expecting. Hopefully it's like that. Yeah.
And like, I feel like it's gonna get just
And then he's gonna ask those radio marks like the reflex.
we don't do all of this.
I'm going to dress. Like, my really important to do good on the first ones because I feel like those pictures are easy. I've always, even the professor said the next culinary exam is going to be difficult. It's good that they're great. I mean, she was fast today.
Yes. Is it motivated?
Master's thesis. They were trying to I find like this. Oh my gosh, super missing. Like hidden underneath the things, but opposition something.
One minute. Oh man. Fuck. We started. This recording's gonna be long as shit. I want to start uploading these videos in class though. Infectious disease uploaded real quick.
This lecture is not as long as the last one. Hopefully it's not as conceptually difficult to understand. So, but I did want to start off with a funny video. Since we just learned about the physical exam of the heart, hopefully this is not you when you actually start to take care of real patients.
Okay, time for the physical.
And
Fuck it up.
Elliot's exam was frighteningly reminiscent of when my older brother used to beat the crap out of me.
See? Isn't so bad. Hold on.
I'm still.
So hopefully that won't be you during phase 2. Or even in ClinCore, since we'll start that up next week. Okay. So, let me get this lecture up. And make sure, yeah, okay, good. All right. So this lecture is going to be all about imaging and ancillary studies to help you with making your diagnosis relevant to the cardiovascular system. Okay. Remember, we said the ancillary study should not be the thing that diagnoses. It should be there to confirm a diagnosis or to help you with your differential diagnosis. You should not order a test thinking this is going to show a heart attack and it shows you something completely different. Hopefully, you think it's a heart attack, you do the test, and it confirms that, yes, they are having a heart attack. Okay? So hopefully no surprises with the results of your ancillary studies. So let's start off with a couple of check-on learnings from the cardiac exam lecture. But our first question is, during which of the following periods is the left ventricle contracting? What are your thoughts? Bravo, correct. Yep. So between the closure of the mitral valve and the opening of the aortic valve is the correct answer. Between the closure of the aortic valve and the opening of the mitral valve, that's during diastole, right? That's particularly called the isometric relaxation phase in that area, but that is not, ventricle is not contracting, it's actually relaxing. Immediately after the opening of the mitral valve, that is diastole, and the ventricle is relaxed during that. And then immediately before the closure of the aortic valve. I mean, it is, but it's also a lot more than that too, right? It's starting to kind of relax a little bit right before that aortic valve closes. Next question. A patient who normally has a heart rate of 60 beats per minute suddenly develops an abnormal rhythm at a constant rate of 180 beats per minute. How does this rapid rate affect the filling of the left ventricle? Bravo. Okay, correct. Yep. So if I am increasing my heart rate, I'm decreasing my diastolic filling time, which means that my left ventricle is not going to fill as much because that shorter diastolic phase of the cardiac cycle. Okay. Then, which of the following valvular lesions typically causes a holo or pansystolic murmur? So looking at it, so pansystolic murmur. So the aortic stenosis, although it is a systolic murmur, it doesn't cause a holosystolic. Remember, you have a period of time where the valve is not open yet in systole at the very beginning, so it doesn't go the full duration of S1 to S2. Same goes with pulmonic stenosis. Aortic regurg is a diastolic murmur, so it cannot be a holosystolic murmur. So that leaves you with delta or tricuspid regurgitation as being a holosystolic. The other holosystolic is mitral regurgitation. Okay. All right. So let's talk about our ancillary studies that we can order in order to come up with the answer and treatment for our cardiac patients. Okay. You can kind of divide these into invasive studies and non-invasive studies. So high-risk studies, low-risk studies, okay? And there's a specific indication to ordering each of these types of tests, okay? You can't just order one test expecting this answer if that test doesn't even test for that, right? If I want to get an EKG, am I going to get an X-ray, right? Does that make sense? I got to make sure that the test that I'm ordering, I got to know what the indications are for that test so that I can get the answer that I want, okay? So there's so many different tests out there that you can do for your cardiac patient. So know what you're looking for when you order those studies, okay? So let's first start off with talking about the chest X-ray, okay? One of the most common studies you're going to get when you're assessing a cardiac patient, okay? And the reason is it doesn't give me an answer, it doesn't give me information that tells me how exactly the heart is functioning, meaning I don't get an ejection fraction from it, but I can look at the functional impacts of the heart. So if I have a heart condition, I do a chest X-ray, it may show a finding, i.e. if I have a patient who has heart failure, and now I'm having fluid accumulating in the lungs, I can see that pulmonary congestion on chest X-ray, right? The other reason that this tends to be one of the more common studies we can order is, one, it's cheap, but two, it can help me with my differential. So when I have a patient coming in with chest pain, yes, it could be cardiac, but it could also be pulmonary, it could be GI, it could be musculoskeletal, it could even be psych, right? Your differential includes all of those things. So a simple chest X-ray can show me, do I have pneumonia? Do I have pulmonary congestion? Do I have attention pneumothorax? I can get that information by doing the chest X-rays. That's why it's one of the more common studies we will get for our patients. And the information that you can get simply by a PA and lateral is pretty broad. So I can evaluate the cardiac silhouette that you see here, okay? So cardiac silhouette, I can look at the cardiac configuration. So is it enlarged or not? Is it in a different type of position or not? Is there calcifications? I can look for any like surgical artificial devices in there. I can get an idea of what's going on with the great vessels. I can look at the lungs. And then I can also look at other structures in that area. So like more along the musculoskeletal area, looking for like rib fractures or something wrong with the bones. Okay. So a lot of information with your chest X-ray. And you can kind of see, based on just the haziness and the silhouettes, the different anatomy locations of the heart and the different structures of the heart based on looking at that. So there's a lot of detail that you can get from a chest X-ray. So here's 3 examples of 3 different pathologies. What do you think is going on in example 1?
Tamponade.
It's called a water bottle sign. Okay. When we talk about pericarditis and pericardial effusions, we'll see why that's considered a water bottle. This is not your Yeti or Nalgene or your Stanley Cup. This is from back in the late 1800s, early 1900s, what a water bottle looked like. So, water bottle sign. Oh, sorry, spoiled it. Example 2 is cardiomegaly, so the heart itself is enlarged. And you can see a lot of other additional haziness around there, so there's probably some pulmonary congestion. What do you think is going on in example 3? Tension pneumo, right? You see a deviation of the mediastinum, you see the deviation of the trachea, you see a collapsing, like loss of the lung findings there on the patient's right. So, yeah, so a lot of information you can get simply by doing plain film chest x-rays. The other nice thing is when you're in a deployed environment, you may actually have access to an x-ray machine. I don't know if you've ever seen the little expeditionary portable x-rays, but you may have access to that in your BAS or in one of your small facilities. So you can actually have that. I will have plain film capabilities on the carrier. I will not have CAT scanner capabilities, which sucks, but I will have plain films. Speaking of CAT scan, cardiac CT is becoming more and more popular of a tool because I can get a lot of good information when it comes to looking at like the great vessels, the pericardium, the myocardium, and the coronary arteries. So I can get a CAT scan to assess for cardiac risk, cardiac disease, before that patient ever develops a heart attack. Okay? So this is becoming more and more popular in evaluating our patients who are maybe otherwise low risk for cardiovascular disease. But you can see the different things that you can diagnose based on this. But there's always advantages and disadvantages for any of the studies that we get, right? Disadvantages of CAT scan is I have to do contrast dye, so an iodine-based contrast dye. Somebody who already has renal failure is not going to be able to tolerate it without me damaging their kidneys further. If they have a shellfish allergy, which I know this is starting to get controversial, whether or not you can still give IV contrast for CTE if they have shellfish allergies, whatever. But typically, we do not do contrast CTs, and so folks who have iodine or shellfish allergies. So there is a risk of an allergic reaction to it from the contrast dye. It does require radiation exposure, so that's always a risk, especially if they're going to get repeated scans. But one of the main things, and one of the main limitations of the chest CT is it doesn't tell me what the ejection fraction is. So I cannot get a functional assessment with a CAT scan. A lot of times that's what we want to know. How well is that heart functioning? So ordering a chest CT is not going to be adequate if that's what your sole motivation is in ordering that test. Now, advantages include I can get a pretty good evaluation of the coronary arteries. Here's an example. So the colorized version, this is a 3D reconstruction based on just a regular CT scan. And you can actually map out how the coronary arteries flow over the myocardium. I can see that path going through. Now, when I go back to the original images, I can see calcifications developing. So here's what I assume is the left anterior descending. You see all these calcifications in the red circle. That's a pretty good detailed analysis of what's going on in the coronary arteries without having to do an invasive test. Okay? And if you're wondering, well, how good is that versus this gold standard, which is the cardiac catheterization, here's an example for you. Okay? So on the left is a coronary CT. So you have a CT scan there on the left, you can see the narrowing, you can see calcifications, and you can also see stent placements, okay? This CT scan was done on the same person as you see with this cardiac cath, and that's what you get with a cardiac catheterization, where I'm directing where that contrast is going to map out the coronary artery. So you can see the information I get is just as good, maybe even a little better than just the gold standard cardiac catheterization to map out the coronary artery anatomy. But it does more than coronary arteries. You can look at the pericardium. So this is, you see the stars on the left-hand image. That is excess fluid in the pericardial space, okay? Now, if CT scans are available, well, MRIs are probably better, right? In a way, it's better, but we typically don't use cardiac MRI unless we're doing either congenital anomalies, so we're looking for congenital anomalies, or we're preparing for surgery, okay? And the reason for this is it is so expensive to do a cardiac MRI, one. Two, what's the heart doing as you're doing the MRI? It's moving. What does movement do to MRI imaging? When you get your knee MRI, are you allowed to sit there and just kick? No, right? You're going to distort the images. You're going to get a lot of distortions and a lot of artifact to it. Same goes with the heart. So actually, when you do a cardiac MRI, when there is an indication to do cardiac MRI, you actually have to do pretty high doses of beta blockers to slow the heart rate down. Okay, just to try to get clearer images. So what are some additional benefits, though? If that is a test that we can order, there's got to be benefits. How can I justify to the insurance company to pay the big bucks to get this MRI? Well, I can get pretty detailed soft tissue analysis without the use of contrast. So if I have a patient who can't tolerate CT contrast, maybe I can evaluate the same things, but with an MRI and not give them contrast. Okay. Plus also the contrast that you can use for MRIs is gadolinium. So it's not something that renal failure patients can't get. So it gives you a suitable alternative if they cannot tolerate a CT contrast. The other advantage for this is if I do a contrast study, I can determine if this area of this heart, this portion of the wall of the heart, it's not moving. Is it because it's dead and it's not moving? Or is it hibernating and not moving, right? What does a hibernating animal do in the wintertime? It's sleeping, right? Doesn't mean it's dead, but it's not active, it's not moving, it's not eating, it's not, the metabolic demands are significantly reduced during that phase. Same thing goes with hibernating cardiac tissue, where basically that area shuts down to just basic sustaining life requirements because it's just not getting the blood flow that it needs, so it just kind of shuts down. But if I do a procedure to fix that perfusion problem, now that tissue, those cells are going to come back to life and start functioning again and start feeding and contributing to the function of the ventricle again. So it can help us determine, should I take this high-risk patient and do cardiac stenting to restore blood flow, or it's not really going to mean much for them, let's put on hospice. Okay. So it can kind of give you that answers to those questions. But like we said, disadvantage of it, very expensive. It takes a longer time to get the images. You're looking at about a half an hour versus 2 minutes for a cardiac CT scan. And then it is a big giant magnet, so if your patient has anything magnetic inside of them, they cannot go through the magnet. You can see in this image here, of a hospital gurney or hospital bed that got wheeled into the MRI, and it had magnetic metal on it and went flying into the MRI. Patients have died from that kind of stuff. So don't put your patients with retained magnetic metals into MRIs because it will go flying accordingly. But those studies, MRI, yes, you can get a ejection fraction on it, but it's an expensive way to get it. But if I want to determine how is this heart functioning, what's the best study I can order to do that? It's your echocardiogram, or an ultrasound of the heart. Because when you look at what the primary indications for ordering an echo is, I can evaluate the internal cardiac anatomy, so your chambers, your heart valve, your chordae, and all those other structures I can evaluate using the echocardiogram. I can also assess function, so I'll get an ejection fraction, but I can also assess the direction of blood flow. So is the flow of blood going in the correct direction, or do I have a regurgitation and now I'm having a backwards flow of blood going in the wrong direction, okay? So lots of good information that you can get with the echo that you cannot get with most of the other studies that we're going to talk about. Lots of things that you can use to diagnose, or use the echo to diagnose. Advantages of it, okay, we talked about assessing function. We also talked about how, there's also a lot of different kind of modalities that we can do to kind of get additional information, so we can kind of tweak how the information is being processed. We can also tweak how it's done, and this is like a transthoracic versus a transesophageal. I can do a bubble study, which is a study that's done to assess for a patient who's had a stroke, who should be like otherwise low risk for a stroke. You can assess for a patent foraminovalle, which we'll talk about on Friday in more depth. But you can do all kinds of things to modify that echo to get additional information. What's the problem with it? Well, if we have to do a TEE, a transesophageal echo, it requires sedation. So is the patient going to tolerate sedation? It also requires passing a semi-rigid scope down into the esophagus. When I'm passing semi-rigid things through hollow viscous organs, there's always a risk of perforation. And imagine what would happen if you perforate the esophagus into the chest cavity. That patient's going to get sick, if not bleed out and die. So there are disadvantages for it. The other thing is your patient's habitus. So if you have a obese patient, or you have that patient who had the COPD barrel chest, where now that AP diameter is affected, maybe my ultrasound probe will not penetrate deep enough to actually see the cardiac structures that I need to see. There's too much tissue that it has to go through. Okay? So there are a couple of disadvantages, but they're not necessarily they're not like some of the other disadvantages that we talk about with like cardiac CT or cardiac MRI. There's ways to work around it, but there are disadvantages for it. So if we have the ability to do a transthoracic echo or transesophageal echo, why would you do one versus the other? Well, you can see the transthoracic echo is a low risk procedure. All it is the probe goes on the external skin of the chest, and they look at different windows and get the images and see the different structures that they need to. But a transesophageal echo, it's a higher resolution imaging. So if there's subtle findings that I'm just not quite sure about, which we'll talk about an example of that tomorrow, I can do a transesophageal echo and I get a higher resolution to kind of look at that. So I'm looking at a high def type of picture, 4K versus 720, right? I can look at valvular vegetations. The left atrial appendage is not well visualized on a transthoracic echo. So the transesophageal echo is required if you have somebody who has a like AFib for a while and you're thinking about shocking them back into a normal rhythm. You typically have to do a TEE first, make sure there's not a clot in that left atrial appendage before you shock their heart back into a normal rhythm and throw that clot up to the brain and cause them to have a stroke. Okay. But there's lots of indications for doing echoes. There's a lot of different pathologies for doing the echocardiogram. And you can distort or you can modify the images based on what you are looking for. Now, this may be a thing that you don't necessarily have to know. I need to do an M1 or a 2D or a 3D thing. You just put in your reason for doing the echo. Hey, I'm looking for this. And the echo tech and the radiologist will process it to do the right stuff, okay? So you don't have to know which version or 2D, 3D, or M mode to be able to get it. Just put in what you're looking for, and the tech will do what's necessary. Okay. But based on the images and the results you're getting with that echo, you can compare that to the gross anatomy, and you can see this makes sense. So the way this view is looking, you're looking at the apex up towards the heart. So this is probably like a subxiphoid view. And you can see the heart's basically upside down. So now you're looking at that left ventricle, like from the apex, and it broadens out into the mitral valve. You can see the mitral valve on that echo, and then that leads into the left atria. And then I can measure the sizes of those chambers and everything like that. But that's the echo. And that's why it's one of the more common cardiac studies that you're going to do for your patients, because it gives you a lot of information that other tests cannot give. But we looked at coronary artery, not necessarily perfusion, but we're just looking for the anatomy of the coronary artery. We're not looking at how well that coronary artery is functioning with the CT scan, right? To be able to actually look at how well you're perfusing an area of the heart, you need to be able to do a perfusion study. And this is where you're going to have to do a nuclear medicine test, like a SPECT scan or a PET scan, where you actually will inject a radioactive nucleotide, let it circulate through, and then you take images, and you can see how well that area of the heart is perfused based on being flagged with that radioactive nucleotide signaling and being detected. So that is an additional test. Then you have also the EKG, probably the most common cardiac exam or ancillary study you're going to order. And I'm not going to test you on EKG questions, because that's why you have EKG class 4. But what is a limitation of your EKG? It's only electrical activity. How long of a snippet in time are you analyzing? 10 seconds. So you're only analyzing for 10 seconds. If I have a patient who is having what I suspect is a cardiac arrhythmia 3 times out of the month that lasts maybe 20 minutes at a time, how likely, if they're not having symptoms, am I going to be to catch that arrhythmia with a 10-second snippet of time? Highly unlikely, right? So what can I do to get more than 10 seconds of time to evaluate the EKG? And that's where you have continuous recording monitors, such as Holter monitor or a Zio patch, where these are wearable technology that the patient will go about their day-to-day business, but it's sitting there recording their EKG as they go about their day. And the hope is that I'll be able to capture an arrhythmia with this monitor on. but I'm kind of limited based on a Holter monitor. You think of about 24 hours, 24, 48 hours at most that you can actually have this on. So if again, I'm only having this arrhythmia happening 3 times a month, but I can only have it on 2 days, what's the chances are going to catch that? You may, but the diagnostic yield is still pretty low. So they came up with a different way to analyze the cardiac rhythm, and that's the Zio patch that you see on this bottom image. And you can leave this on for 14 days, and there's even versions where you can leave this on for 30 days. So what are the chances you're going to capture an arrhythmia if you have a Zio patch on for 30 days and they have this arrhythmia occurring, or they're having symptoms of an arrhythmia occurring 3 times out of a month? Highly likely, right? So a Zio patch can help increase your diagnostic yield by monitoring the EKG, the conductive circulation, for a longer period of time. It's also better well tolerated. It also tends to signal things. So if something happens, like you go into a really abnormal rhythm, it can flag you, ping to the monitoring center, and then they can trigger calling you to go to the emergency room and those types of things. So the Zio patch, a much more modern Holter monitor, a lot better tolerated, stays on longer, and everything like that. So probably as a primary care provider, you're going to be ordering Zio patches a lot more than Holter monitors. But what's the problem that we have with all of the tests that we just talked about? They're all at rest. When you think of a patient who's having cardiac disease, when do they have symptoms? When they're sleeping? Or is it when they're active? Okay. So if I'm only doing tests that test a patient at rest, does it make sense that I'm not getting the full picture of what's going on? Great. This EKG is completely normal at rest, but as soon as they get out of that chair, they have a heart attack and die. We didn't do anything to evaluate activity. And that's where this stress test comes in. And all of those things that we just talked about, I can do a stress version of that. Okay? Chest x-ray, maybe not, but looking at the EKG pattern, I can do a stress test version of that. The echocardiogram, I can do a stress test version of that. The myocardial perfusion scan, I can do a stress test version of that to kind of see what happens, what changes occur with activity compared to rest. Okay. So let's talk about, this is a stress graded exercise treadmill stress test. Okay. So you can do this on a treadmill, or if you have a patient who's elderly who can't run for 10 minutes, then you can do a chemical stress test where you give them a shot of dopamine, I think it is, dobutamine, and it will speed up their heartbeat, so it kind of mimics a stress load. But the typical thing that you're going to do for your low-risk patients to assess the stress test, and particularly the EKG version of the stress test, is doing this treadmill stress test that you see here. And basically, this person's going to start off slow on the treadmill, and then it's going to increase in intensity, it's going to increase speed, it's also going to increase the incline as well to make the patient work harder. And basically, you're trying to get the heart rate up to a certain value to be able to say you've completed the stress test. Meanwhile, while they are doing this, they are wearing EKG leads. And you can kind of see these EKG wires hanging off of the patient. And imagine running with all these wires hanging off of you. It is a challenge, but we do it. But what we're doing is, and you can see the computer monitor there, you're sitting there analyzing the EKG. You get the resting EKG, and then as they're running on the treadmill, it will keep comparing that lead to what their baseline resting EKG looks like. And you can catch distortions of the ST segment or the T wave early. So if you start to have ST depression or ST elevation, or even a T wave inversion, you will see this change occurring while they're running on the treadmill. Then you know that this is a positive test. Okay. But at rest, their EKG was completely normal. But as soon as we stressed them, it went abnormal. And there's very few contraindications to actually doing an X-ray or doing a stress test. Does it make sense that if they have any active disease, probably not the time to be putting them on a treadmill? Could make sense, right? So if they have they're having an active heart attack, let's not make it worse. Let's just bring them to the cath lab and fix the problem, right? But there are few absolute contraindications to doing a stress test. Then we have the stress echo. So we said the echo is great at assessing the function and the anatomy, the internal anatomy of the heart. Well, the stress echo, I take images at rest and then I stress them either by having them run on a treadmill or have them run around the hospital for a bit or give them a chemical injection to speed up the heart rate. And then I repeat that echo and I can actually compare the two and see what the images look like. And I got a YouTube video that kind of illustrates this. So let me switch over to that.
To help with the interpretation of regional wall motion, which is not the easiest thing to do, this particular program has what's called a regional wall analysis guide. If we stop this process on frame 1, which is end diastole, we can use this regional wall tool to outline the endocardium in diastole and all the walls if you want. And we can do this at rest. And we can do this in any one of these. With exercise. And then when we hit go.
So we marked out the borders.
I'm sorry.
And then when he starts the images, you can compare.
We can immediately see that at rest, all the systolic frames exceed and move towards the cavity compared with where it started in green. But that's not the case with the post. You can see that the proximal septum is moving quite vigorously, whereas the more distal septum hardly moves at all. The posterior wall is continuing to move normally. By the way, I did use the word posterior rather than inferior lateral.
So, same. So same images, one at rest, it looked like the heart was functioning fine, and then one with stress or exercise or chemical stress, and now it wasn't moving normally. So that's what a stress echo can do. So functional change with stress. But we want to know what's going on with the perfusion of the myocardium with stress, right? Because this is potentially the decision point that we're going to have to make on whether or not this person needs to go get a catheterization done, to get stents placed and those types of things in order to fix that perfusion deficit, And you can see here, we take images at rest, and you kind of see that blood flow is pretty adequate, right? It looks bright, makes me reassured, right, in different types of views. But now let me stress the patient. Now compare, this is the same patient, compare those two things, these two things, and these two things. They should look the same. Do they look the same? No, right? This is somebody who should have been in the cath lab last year, okay? Because the perfusion with stress or with activity is so bad that a large portion of myocardium is not getting adequate supply, okay? Then there's blood tests, and there are so many different kinds out there. I will simplify that to this list. This is what we're going to talk about from a blood test standpoint here in cardiovascular. So cardiac enzymes, we're looking for any evidence of like infarction or ischemia. Lipid panel, of course, that makes sense. Why do we check lipids? We're checking for cholesterol. Do they need to be on statin therapy or not? A BNP, brain natriuretic peptide, is a test for heart failure. A D-dimer looks for blood clots in like the legs or like pulmonary embolisms. A basic metabolic panel or a complete metabolic panel, BMP, CMP. They tell me electrolytes. They tell me electrolytes. They tell me kidney function. The CMP adds liver function onto the basic metabolic panel, so I can kind of see those things. I can also see with the liver function standpoint, is the liver getting perfused properly? Or is it dying because it's not getting the perfusion it needs? And you see those enzymes start climbing and going through the roof. And then, of course, a complete blood count to look for anemia. Also look for platelets, right? That's also relevant to the cardiovascular system. But we can, with the CBC, we do that. So this is the list of blood tests that we are going to talk about during the class. So that is your non-invasive tests, okay? If we have non-invasive, then we probably have invasive tests too, right? And the two kind of main types of invasive tests that you're going to have are cardiac catheterization and electrophysiology studies. And why do we order one versus the other? What is the difference? We're going to talk about here. Both of these tests are done in a suite that looks like this. You can see sterile gowns, sterile table full of instruments. The patient has sterile sheets on. You can see the giant C-arm here, so you're able to take x-rays. And then there's computer screens that not only show the EKG of the patient, but also will show you what the x-ray images are with the fluoroscopy that you're doing with the C-arm. But you can see this is what a typical catheterization suite will look like. And when you say go to the cath lab, this is what the cath lab is. Okay. So when we do cardiac catheterization, this is an invasive test that involves threading wires and catheters through either arteries or veins, depending on if you're doing a left or a right-sided catheterization, to be able to get diagnostic information, but also, depending on which one you're doing, you may be able to do therapeutic things as well. Let's talk about left heart cath, okay? Left heart cath, you thread the wires through the arteries, and you can go in a number of different arteries. You can do the femoral artery and thread all the way up through the aorta, all the way up into either the left chambers of the heart, or if you're looking for coronary arterial disease, then you're going to thread it into the coronary arteries themselves. You could also thread it through your brachial artery, which that's what I've seen most commonly in the hospitals. They use brachial artery now. Less risk of infection than the femoral artery, the groin stick. Or you can also femoral, brachial, or axillary arteries. So there's 3 arteries that they can cannulate in order to get the wires where they need to do this study. Left heart cath can be both a diagnostic and a therapeutic test. Okay, so that's one of the advantages. We said yes, it's invasive, which is one of the reasons it's not our go-to for things. But if I have a patient who I am going to do an intervention on, then this can offer some therapeutic kind of approaches to it. So for a diagnostic standpoint, I can define the coronary artery anatomy. I can look at LV function, so I can get an actual functional information of how the left ventricle is working. I can evaluate for aortic disease, and then I can also get some other additional monitoring kind of information with that. So this is a diagnostic information I can get with a left heart cath. Now the therapeutic side of it is I can do things like I can do balloon angioplasty, where I'm threading the catheters through the coronary arteries. I come up where there's a blockage that's disrupting blood flow to the myocardium. I can then pass that wire through it, inflate the balloon, and then open up that artery. I can also place a stent across that, where I thread the wires with the stent collapsed into place. I inflate the balloon that's underneath that stent, it deploys it, and now it restores that blood flow without affecting the atherosclerotic plaques. I can also do other things like do valve replacements and some other monitoring or other types of devices for patients who have really poorly functioning hearts. Okay. So that's the therapeutic things that I can do with a left heart cath. And you can actually tell where you're at in the heart based on the pressures that you're seeing. You can see on this graphic here, you know, the left ventricle has a systolic pressure of between 100 and 140. If I were to think I was in the left ventricle and I'm seeing pressures of 15 to 30 with a diastolic pressure, maybe I'm in the wrong ventricle and I'm actually in the right ventricle, right? An additional thing is you notice this pulmonary capillary wedge pressure, this PCW, right up here, is the same pressure as the left atrium. So if I was concerned about how the left atria is functioning, instead of doing a left heart cath, a very invasive arterial stick, I can do a right heart cath, and I just thread those wires through the jugular vein into the right heart structures, and then I can wedge that catheter in the pulmonary artery, and then I can see what's going on in the left atrium. So that's a right heart cath, and typically you'll do this with a catheter that has multiple lines to it. This is called a Swan-Ganz catheter. And all of those different lines can either be used for monitoring different values. It could also be for infusing treatments. So antibiotics, antiarrhythmics, electrolytes, all of those things I can infuse through this. And I can do multiple things all at once through this one catheter that's going into the right side of the heart. So typically we're going to do a right heart cath in somebody who's critically ill, who needs a lot of invasive testing, we need a lot of invasive monitoring in order to regulate their physiology. So think of your ICU patient as having this done. But regardless of whether it's a left or a right heart cath, there are risks for doing it, which is why this is an invasive test. It could be, okay, you're injecting contrast, IV contrast, which is an iodine base, so maybe they're gonna have an allergic reaction. If they have renal failure or renal damage as it is, you may make that worse by doing this study. As I'm threading those wires, again, I'm going through a hollow lumen structure, there's a risk of me puncturing through an artery if I'm doing a left heart cath, or puncturing through a large vein if I'm on the right side. Okay. The other thing is as I'm threading that wire, let me say I'm trying to evaluate this patient with coronary arterial disease. I'm threading these wires and I hit the plaque and I just push. What's it gonna do? What can it do? It can break that plaque off, and now they definitely have a heart attack because you just caused it, right? So the other alternative is maybe it will go up to the brain, and now they have a stroke. So lots of risks associated with heart catheterization, which is why this is not a primary test, especially for low-risk individuals, okay? This is why we have the non-invasive tests to rule out those who don't need to get this invasive testing done in order to save their lives. Now, electrophysiologic study starts out the same way as like a right heart cath, but you have these electrodes that will go to specific locations of the heart. And what you're doing with this electrophysiologic study is you're interrogating the conduction pathway. So you can see that one line goes up to where the SA node is. The other line goes to where the location of the His bundle is. And the other one goes down to the kind of towards the apex of the ventricle. So you can kind of see what the conductive path is there and like the Purkinje fibers is. And basically, you do this test in somebody who has like an arrhythmia, especially like a recurrent arrhythmia, and you're trying to find out where the short circuit is located so you can kind of snip that wire, right? So you'll do the diagnostic part to it, find where that short circuit is, then I can do a therapeutic thing where I do an ablation and I kind of think of it as I'm cutting that short circuit wire so that that arrhythmia cannot use that short circuit in order to cause that arrhythmia to happen. So an electrophysiologic study would be things like doing, if you have like an AV-NRT, I think you probably talked about that in EKG. If you haven't yet, you will. But people who have these recurrent episodes where their heart rate will speed up all of a sudden, they can undergo this and it will fix that short circuit and get rid of it. Wolff-Parkinson-White is another example to treat this. Okay. So that's all of our diagnostic things. One thing I did add for this, this class, because I had gotten a lot of questions before, if you've never worked and seen what a hospital really looks like, I will throw out this person should go to the ICU, this person should go to this place or whatever. This is just kind of showing you what the differences are in the different levels of care in the hospital, okay? So this is a pretty typical ER. You're looking at it, you got monitors, you got vital signs, you got IV poles, you got a bed, particularly a gurney, not a very comfortable bed. But typically, depending on the facility you work at, there's going to be a patient-to-nurse ratio that has to be observed. And it could be depending on acuity. So if you have a really, really sick patient, it may be one nurse per patient. But if they're lower acuity, they're not so sick, maybe they don't even need to be at the hospital, but because they don't have a primary care provider, they just go to their hospital whenever they feel like it. Then it could be that you have one nurse for every 4 patients or one nurse for every 5. There's protocols in place based on the facility that you're practicing at. But the ER is there to diagnose the condition, not necessarily there to manage it, especially if it's a chronic condition, right? Patient comes in with regular high blood pressure and they just need to get their medications refilled. They should not, hopefully, The patient should not be coming back to the emergency room to make that assessment if that blood pressure medicine is adequate or not. They should be going to a primary care provider to manage those chronic medical conditions. Unfortunately, in the United States, it seems like ERs are being used more and more as primary care facilities because we have such a shortage of primary care providers, and it takes a while to get into your PCM. So let's say that this patient is too sick to go home, but they're not critical. They're not extremely sick, but they just can't go home because we gotta watch them, we gotta start treatment and watch them how they respond to it. Or maybe they need like IV antibiotics for a period of time before we transition to oral antibiotics. We can admit them to the hospital ward or floor. And you can see in this room, compare what we saw in the ER room to what you see in this ward or floor room. Yes, I've got a computer on wheels, right? So the nursing staff can do their documentation that they need to for the patient. But do you really see monitors at all? No? You see a blood pressure cuff that's really not working. I don't see a cuff on there, right? But I don't see a lot of equipment. So does it make sense? If I don't have a lot of equipment at the bedside, then probably that patient is not that sick, okay? But they're sick enough that they can't go home. The nurse-to-patient ratio in the hospital floor is going to depend on the facility. It may be one nurse for every 4 patients or one nurse for every 6 patients. And you may even, in some like civilian type of hospitals, even be in excess of like 10 patients. But typically, in a hospital floor, the nurse should go and see their patient every 4 hours. Okay? Should not be somebody who is too sick that I cannot go 4 hours without checking on them. Okay? That's what would meet the criteria of going to the hospital floor or the ward. Now, a telemetry ward is somebody who you have a suspicion for cardiac disease, but they're stable. But you want to monitor them closely. So they can get admitted to the telemetry ward, which basically you see on the patient, he's got this little box on his chest here. This is basically an EKG that's attached to this box that transmits the signal to a central monitoring location where there's somebody whose job it is just to sit there and watch these EKGs for 10, 15, 20 patients to see if anybody's going into weird arrhythmias and be able to diagnose it. Not all wards are going to be telemetry wards, okay? So you may need to put them on a specific ward if you have a patient who you suspect has cardiac disease. But you can see these patients are stable, so the ratio of nurse to patient tends to be the same as it is on the ward. Now you may hear of a step-down unit. Kind of think of this as a mini ICU. This is patients who don't technically require critical care access, but they're still sick enough that they can't go 4 hours without getting checked on, okay? So they can go to the step-down. And in the step-down, the ratio of nurse to patient, like 1 to 3, 1 to 4, depending again on your facility protocols. So patients more sick than the floor, but not so sick that they required the ICU or the intensive care unit. But you look at it, okay, there's a lot more equipment in that room, right? This patient has a higher risk of going downhill, so we have to have that equipment at bedside in order to manage that patient. But compare that to the ICU, where look at the amount of equipment that is present in that room. These are going to be your patients who are extremely sick, who need like IV medications around the clock to regulate their dynamics, the physiologic dynamics, like their blood pressure or their heart rate, the strength of the heartbeat, all that kind of stuff. They need invasive monitoring, so we talked about that Swan-Ganz catheter, doing like a right heart cath. They're going to be in the ICU because of that invasive monitoring device. But because these are sicker patients, look at the nurse to patient ratio. could be 1-to-1 or 1-to-2. So imagine the cost associated with being in the ICU compared to being on the regular floor. At a minimum, the nurse should go and evaluate the patient roughly every hour in the ICU to make sure they're doing okay. So that means like taking vital signs, that's doing assessments, they're interacting with that patient at least one time every hour. So that's the different levels of care. The intensive care unit could be a cardiac care unit. We have a cardiac care unit here at BAMC. Does that really matter? Not really. So when it comes down to just placing patients, let's just put the patient in the right bed and move forward. So it's not like all cardiac patients have to go to the cardiac care unit. It just means they have maybe a little better training to manage cardiac disease compared to other critical care plans. So, questions on diagnostic studies? Okay. I know I went a little later than my 50 minutes, but I figured you wanted to get out of here instead of a 10-minute break and then another 2 minutes. So I'll see you all